Good morning. Just as everybody is filtering in, I'll just start with the housekeeping notes that I have. So I'd just like to welcome everybody to this morning's session, which is the Paediatric refresher session, and we're in Arena 1B, just to make sure that this is where you wanted to be. Please make sure all your mobile phones are switched off or on silent, please. For the organisers, if you're deciding not to attend any of the social functions, could you just please let them know at the registration desk? Also, please download the Congress app from the App Store. Sorry, I'm so computer savvy. And through that, I've found out that you can send questions to me, so please feel free to do that, and hopefully I will be able to pick them up and ask them of our speakers. My name is Fiona MacFarlane. I've been asked to chair this session. I'm the current president of SPANZA, the Society of Paediatric Anaesthetists in New Zealand and Australia. So what I would like to do is ask our first speaker to come to the lectern, Phil Stevens. Phil is from the UK and has been in Australia for 19 years. He has a rather illustrious career, having spent time at Great Ormond Street in Adelaide, the Royal Children's in Brisbane, and the Mater Children's now also in Brisbane, and he's been there for 13 years. His interests are in acute pain and TIVA anaesthesia, and he's also now branching out into areas of hypnosis. Thank you, Phil.
So this session is designed as an update for those anaesthetists who don't have a major paediatric interest, but I can see the audience is packed with ones that do. I hope you can be entertained, if not informed. So why? Why are we discussing tonsillectomy again? This can best be answered by this, the July edition of Anaesthesia and Analgesia, which had an editorial, The Elephant in the Room, Lethal Apnea at Home After Adenotonsillectomy, and an article, Death or Neurological Injury After Tonsillectomy, with a focus on obstructive sleep apnea. Houston, we have a problem. Well, I reckon if you've got an elephant in the room and you think NASA are going to solve the problem for you, the problem may be a bit bigger than you think. So what we need to understand is that since 1976, when sleep apnea was first described in children, there's been a progressive increase in the number of adenotonsillectomies performed for obstructive sleep apnea and a concomitant decrease in the number performed for recurrent tonsillitis. And overall, this approaches 80% in the USA, and in children under 3 may approach 100%. Obviously, those proportions aren't replicated in every region of the world. At the same time, there's been a progressive decrease in the length of stay, exemplified at its extreme by day case anaesthesia for tonsillectomy. And when we throw into the mix the increasing rates of obesity in children, this has resulted in which Charles Cote in the article described as a perfect storm of potentially inadequate preoperative assessment and inadequate postoperative observation. And so now we've got an elephant in the middle of a perfect storm, and that's why we're talking about tonsillectomy yet again. So I'm going to try and deal with the issues you've got up there: preoperative assessment, anaesthetic technique, dexamethasone, non-steroidals, and discharge analgesia. So the purpose of preoperative investigation, you could say, is to confirm the diagnosis and stratify the risk, because there's no doubt that increasing severity of OSA increases the risk. So I'm not going to read them out. But the risk factors for getting OSA are on this slide, though you don't have to have any of them to have obstructive sleep apnea. And the symptoms and signs are here. So the diagnosis is not easy to make. Might seem easy, but it's not. At one extreme, the gold standard is the sleep study, expensively impractical, and at the other end is clinical diagnosis, inexpensively imprecise, and overnight oximetry probably lies somewhere in between. So without some assessment of the severity of obstructive sleep apnea, it's difficult to decide an appropriate level of post-operative care. In Australia, nearly all, I thought it was all, but I've been proved wrong, nearly all patients with a provisional diagnosis of obstructive sleep apnea stay in hospital overnight and have access to pulse oximetry. So the question largely relates to which patients need to have access to ITU and HDU. And this slide shows what are considered to be the risk factors for complications in patients with obstructive sleep apnea. And it has been suggested that ITU be reserved for patients with severe recurrent hypoxia, age less than 2, and a medical comorbidity possibly. But clearly there is a continuum of risk here. A pragmatic approach to which patients might be safe to discharge is if they've shown no oxygen requirement overnight and no significant desaturation. But the Cote article, which I would remind you comes from America, point out that 4 deaths occurred over 24 hours after discharge, and some patients have died after spending a night in hospital. So from this point of view, a blameless post-operative night is no guarantee of safety, and it's worth remembering that tonsillectomy is not immediately curative of obstructive sleep apnea, and in some cases not at all. So there's no slide for the next part because it's just opinion. There's really no universally accepted technique for adenotonsillectomy. If you believe, as some do, that the patient's intraoperative response to opiates gives some indication of their post-operative sensitivity, that's going to nudge you in the direction of attempting a spontaneously breathing technique. If you're worried about airway fires, that's an argument for the use of a cuff tube. And if you wish to maintain an open airway in recovery during emergence from anaesthesia, you may, with the agreement of the surgeon, use a laryngeal mask or place a nasopharyngeal airway. Are there as many anaesthetic techniques as people in this room? Pretty close, I would imagine. So we'll turn to a slightly simpler issue, dexamethasone. As we know, dexamethasone is widely, I might almost say universally used for tonsillectomy. And the Cochrane review, updated in 2011, concluded that a single dose of dexamethasone was safe and effective in reducing vomiting and pain and promoting a diet return. The dose range examined was from 0.15 to 1 milligram per kilogram. And this data is really substantially based on big dose steroids. Only 6.7% of the patients were in trials where less than 0.2 milligrams per kilogram of dexamethasone was used. A survey of practice of tonsillectomy in the UK showed that the majority of anaesthetists gave a dose of 0.1 milligram per kilogram with a maximum of 0.25. And this would mirror the practice in my institution, the Mater. So this is an antiemetic dose. I don't think there's much doubt about that. But it's on the very edge of the evidence base for the other benefits claimed. Now, some anxiety has recently been expressed that dexamethasone may increase bleeding after tonsillectomy. And a cynical person like me might note that these reports came out fairly soon after a meta-analysis suggested that non-steroidals did not increase the bleeding risk. I think William Shakespeare identified the reason why patients bleed after tonsillectomy 400 years ago. There's recently been a huge retrospective audit in America of over 139 patients looking at whether dexamethasone produces a clinical risk, and they concluded that the risk of bleeding, though observed, was negligible and did not warrant any changes to current practice. I think, I haven't read them chapter and verse, but I think the articles showing bleeding after dexamethasone, again, a big dose steroid, so maybe it's a dose-related thing. Moving on to analgesia now. So, again, this is my opinion, based on the inordinate number of papers published describing different techniques for tonsillectomy, but it probably doesn't matter as much as some people think what analgesic you give in hospital, providing the patients are safely monitored. But I am going to grasp the thorny nettle of the non-steroidal. So this is a perennial topic. It's been done to death, but that's not going to stop me having a go at it. Is there any evidence that non-steroidals increase the risk of bleeding after tonsillectomy? Because there are alternative analgesics which we can use in hospital, I think the question that we really want to answer is there any risk of bleeding from sustained use of non-steroidals as a post-discharge anaesthetic? And in practical terms in Australia, that means the regular use of ibuprofen. Now, within the trials in this Cochrane review, there were 1,101 children who received non-steroidals, and only 137 of them were patients having what we're interested in, regular post-operative ibuprofen. The conclusion of this study was a double negative: insufficient evidence to exclude an increased risk of bleeding. So, on this basis, I would suggest there's really no good evidence from randomized trials to guide our use of non-steroidals. One would imagine that a comparison of the bleed rates between countries where non-steroidal use is common and ones where it is uncommon might give us the answer, but as you can imagine, that would be fraught with difficulty. So, the mainstay of analgesia is still paracetamol, which now seems to be regarded by some of our nursing staff as a near poison. Certainly it's not without its risks, but I think those are mainly in out-of-hospital use. It's been an act of faith in paediatric pain management for many years that a combination of paracetamol and ibuprofen is better than either alone. But we've got our friend, I don't know if he's here, he usually is, Brian Anderson, to thank for actually examining the subject. And he's concluded that there's undoubtedly a benefit of adding ibuprofen to paracetamol. In the reverse situation, if you've got ibuprofen, is it worth adding paracetamol? Well, yes, if the dose of ibuprofen is 5 milligrams per kilogram, but As you start going up towards 10, the benefit becomes less apparent. So now we're at narcotics. You can just track across this slide to see that in the obese child with obstructive sleep apnea, the risks progressively accumulate to the point where catastrophe is possible. And then we have codeine, a previously popular and apparently safe analgesic. But now, because of its ultra-rapid metabolism in a very small percentage of people, and certainly in Australia a very small percentage of people, it's not recommended in Europe or America anymore. The TGA here have reported no deaths in children having codeine after tonsillectomy, and they've said professionals may wish to consider an alternative analgesic if codeine is used for the lowest dose and the shortest time. So our options for pain relief are fraught with risk. To raise the stakes further, we were recently reminded how miserable children can be after this operation. And just to prove I'm not a paper reader, but actually a researcher, I'm going to put up some published data of my own, which illustrates this and shows this work was done in 2000, so nothing's changed. Patients are in severe pain after this operation. A follow-up paper explored the barriers to analgesia, which serves to remind us that even if we had a safe and effective drug, there's no guarantee that it will reach the patient. And again, this is illustrated by my data, showing that even when parents recognized that their children were in severe pain, most of them still only gave them paracetamol. So, although hospital doctors, whether they be surgeons or anaesthetists, may make recommendations about analgesia, once discharged, patients may also seek pain relief from GPs, A&E departments, and even buy stuff over the counter. So there's not a single practitioner in control of the situation, which makes it difficult. But in conclusion, tonsillectomy remains one of the commonest surgical procedures carried out in children, but its major indication has changed, and this has altered the risk profile. And this has occurred against a background of an epidemic of obesity, a trend towards earlier discharge from hospital, and a heightened awareness of the challenges of pain relief. So the final controversy is which anaesthetist should be involved. And I'm going to leave Arnold Palmer to have the last word. Thank you.
Thank you very much, Phil. We're going to leave questions to the end. I should just mention the topics that we've chosen today are things that have been discussed at SPANZA meetings over the last sort of 2 years, and they're topics that are quite controversial amongst paediatric anaesthetists as well. And I very much hope that with the next talk from Peter, that I can go away and 100% of the time absolutely guarantee that I can predict how a child is going to behave as I get them off to sleep. Peter is also from Brisbane and works at the Royal Children's Hospital and also in private practice. He spends 80% of his time in paediatrics and has interests in regional anaesthesia. Thanks, Peter.
Thanks, Fiona. All right, so we've got the light-hearted topic of avoiding Brutane, and I think this is something that all of us who look after children want to do. We've all encountered the feel-bad experience that is the screaming patient, the crying mother, the tense, frowning father, the staff who are looking at you with wide eyes, and you know that afterwards there'll be a degree of self-reproach. So how can we predict and remedy these problems? Well, why is the patient reluctant? And there are a number of factors, but there are a few lead contenders. And what on earth can you do with the patient if the mother is anxious? So why is the patient reluctant? Well, there are a number of factors. Frequent flyers with a personal history might have some predictable form. Sometimes the kids are just sick and out of sorts. There are obviously the autistic and psychiatrically afflicted children. There are specific phobias, although I don't really believe too much in specific phobias, and they may come under the bottom category of naughty. So this leads us next to the very old question of when should we apply restraint when we're inducing children for their operation. It's a very old topic, and there are some fairly readily accepted situations in which force is acceptable. Young patients, a procedure that's very fast, it'll all be over shortly, grommets, the parental assent, the mother thinks you should do it, the surgery's urgent, and there seems to be no obvious alternative. Those are reasonable guidelines, but let's put it to the audience with some scenarios. If I can see a show of hands, who's happy to restrain a 3-year-old for grommets? That's right, I think so. What about a 7-year-old who needs his appendix out? Yeah, what else are you going to do? What about an 8-year-old for an elective gastroscopy? Who's really going to hold that one down? It's a tough one. And finally, the 16-year-old autistic boy for dental work. Oh, look, sometimes you just have to. So I think this is by no way scientific, but the crowd's feelings roughly mirror my own on this. But are there any rules? Well, we've got this sort of sentiment, we all feel the same way about this problem, but are there rules, or are we just cowboys on some kind of medical frontier? Well, there are no clear guidelines, and restraint is regarded as a necessary evil. A lot of people have written about this in the peer-reviewed literature, but there's nothing hard, nothing concrete in this field. There is this the issue of parental assent versus the child's consent, and in a small child, parental assent becomes a much more decisive factor than the child's consent. But it is worth touching on this somewhat relevant issue of Gillick competence. This is really nothing to do with anaesthesia, but the Gillick case roughly involved a teenage girl who wanted to get the pill. The GP gave it to her against the mother's wishes, and then took the GP and the local trust to court. So there is this notion that a child who understands what's going to be done has got the capacity to give consent or assent to treatment, and therefore conversely to decline it. A thorny legal issue, and there are much more expert people than myself who might be able to give comments about this. Is cancelling the case an option? Can you walk away from this? There's a lot of pressure. The child's come in fasted, the mother's had a day off work, and cancellation, I think, probably is a reasonable option, perhaps after the failure or refusal to take pre-medication, and if and only if there's a reasonable prospect of improving the situation with another date and another plan. So you have to be prepared. We don't really want to face the situation of cancellation or of sending someone back for another day. The communication is important, not just in medicine, but in all of life, and so you have to have a plan, but more than just having a plan, you have to explain your plan to the patient and the parents. You need to enlist the parents if appropriate, but it is important, while you need to empower the patient, you're in charge. The plan, the success of the plan is your success and the team's success, and the failure is yours as well. So whatever plan you have and you negotiate with the patient and the family, it has to be your plan at the end of the day, because you'll be judged on it. There are a few red flags. Can we speak alone, doctor? Sometimes patients come in uniquely unprepared for the idea of having an operation. This isn't Nana's house. I've seen patients who've arrived thinking they were coming to a party, or that they were going to visit Nana, And so it is very important, even though it seems so obvious, to avoid elaborate lies. You'll be found out, and that trip home in the car afterwards might be a little uncomfortable for the parents. So you need to avoid any ambiguity, and everyone needs to have the same plan. So moving on from those fairly soft issues, we might as well talk about what we can actually do to improve our chances of success. The mask or the needle. I found this representation on the internet of how a child views this mask-needle decision. And in the mind of many children having their first operation, this is how it is. So it goes without saying that first-timers almost always select inhalational anaesthesia. But that is not the case when children have lots of operations, and veterans have preferences, and in fact many repeat offenders come to prefer an intravenous induction. It is important to emphasise, though, that whether you choose the mask or the needle, room air has no sedative properties, and you need to administer some inhalational anaesthesia or intravenous anaesthesia fairly quickly before confidence is lost. So you need to control the environment. You are in charge, so you need a calm, quiet theatre, quite difficult sometimes. Briefly say hello to the staff on arrival, and try not to confront the child with a menacing sight. Not suggesting that you disguise the instruments or anything, but you just don't want anything excessively confronting to greet them. How about a cheerful and pleasant dentist and his assistant? There we go. It's a much less threatening sight. Maintain the momentum. The Australian anaesthetists will be aware that quite recently we've had a bit of a shake-up of our time-out and our final checks, and some institutions have struggled with this in the context of keeping a child moving from the day surgery unit into the operating theatre. So there can be no lengthy time-out check, because no matter if you're interested in patient safety, a screaming child and an hysterical mother will not help you get the site of surgery correct. So come into theatre and begin induction straight away. There's no need to delay, and when the child looks a little bit asleep, ask the parent to go out. There is this exponential decay of confidence and the chance of success with time. The words, "Mummy, I need to tell you something," should evoke, if not alarm, a sense of heightened alertness, and whatever it is, it'll have to wait. So what are you going to do to distract them from making these "Mummy, I need to tell you something" last-minute bids for freedom? It doesn't really matter what you do. I think getting children off to sleep is a mixture of confidence, trickery, and human warmth and distraction. So it doesn't matter what you use. Many of us have songs. I've got one song, and about 3 jokes. So the staff get very tired of these. It doesn't matter. Some people have fanciful stories and can just go off in a stream of consciousness and take the child with them. You must be earnest. They can sniff your anxiety out and won't be fooled. You can have high-tech aids. Some people use an iPad, and that certainly is good. Mindless nonsense is great and doesn't require planning. I quite like a physical challenge, actually, and things like, we're going to see how many times you can empty this large bag of laughing gas. A boy your size should be able to do it 10 times, and if you can have 10 breaths, you're asleep. I have a helpful surgeon who when I occasionally choose intravenous induction, steps up to the patient and says, "Look, when the needle's about to go in, mate, just wiggle your toes." And this works very well, except for the one day when the patient said, "But I haven't got any toes." And so, as a caution, this technique may not be used on bilateral amputees. So we'll move on to something even more concrete and pre-medication. There are 100 different recipes, and all I can offer you are a few of mine. Nitrous oxide. Don't forget about nitrous oxide. I'm a bit of a devotee, and it's been around for 150 years, giving us safe, predictable, and perfectly free from aroma, anaesthesia and sedation. This is how to abuse nitrous oxide from the internet. And don't also forget about the single breath induction. It's certainly a very useful technique for the older teenager and quite frankly the young adult who doesn't want a needle. And if you can have a very long breath sustained for 10 seconds with a bag full of 70% nitrous and sevoflurane, then it is almost 100% effective if compliance is assured. The problem with all of these is you have to figure out which is your target audience, because a nervous 7-year-old can't do the single breath induction. Midazolam, everyone is familiar with midazolam. You can give quite a reasonable dose and it works fast and it makes the child very drunk and occasionally go completely bananas. The downside is it does wear off nearly as quickly as it starts to work. So what else can you use? Well, don't forget Valium and temazepam. Things like diazepam have a lovely gentle onset. They don't give you the same drunk patient that midazolam does, and you can give it at the start of the list and not have to worry about the effect wearing off. It's a very different quality of sedation and it has a very pleasing effect on the parents because the child becomes much calmer. Clonidine has become, it's been a fashionable drug on and off, and it certainly has a place, although perhaps not a universal role in pre-medication. You can give a decent dose orally, and in fact you have to have a predictable response. And it's available as tablets, or just tip it out of the ampoule into a drop of juice. And it does have a similar effect to Valium in that it comes on nice and gently and gives you a simple sleepiness. The timing is very forgiving. You don't need to worry about calling during this previous case. And it provides excellent analgesia for painful operations. So why aren't we giving it to everyone for every operation? Well, because there are problems. It certainly does lower the blood pressure and slow the heart, usually not a problem. It shouldn't be given before a case that's going to lose lots of blood because there definitely is a potent sympatholytic effect. But the most prominent reason I gave up the use of clonidine on a fairly widespread basis was the call from day surgery at 7 o'clock saying that the patient couldn't stay on their feet and that the hernia repair was now 5 hours ago. So it's not a great idea for day surgery where sometimes there is quite a potent residual sedation. It doesn't make them forget. What about ketamine? It is a marvellous drug and this person's enjoying it. You can give it any way you like and once again, like clonidine, it's got a narrow place but it's excellent in its place. You can give a dose of 5 milligrams per kilogram quite reasonably, and it's safe and quick and gives them profound analgesia. There is a very different quality to the sedation. The patient looks quite spaced out and doesn't quite look asleep, which is upsetting for the parents a lot of the time. This is a lovely illustration from the World Wide Web showing that how many ways you can get ketamine into a small child. I don't know if the parents gave it. And then for the refractory child, the child who's been sent home, that 8-year-old for the gastroscopy who just wouldn't comply with the mask needle or the pre-medication and in whom you were unwilling to proceed, you can bring them back and give them a pre-med which is almost guaranteed to work. Midazolam plus ketamine is effectively an oral induction of anaesthesia and does require significant supervision. It can be given in a recovery bay perhaps, and once they swallow it within 20 minutes you've got a reasonably compliant patient. Having said that, it does take a little while for them to wake up. So remember, I think this is from the House of God, perhaps I'm wrong, but the patient is the one with the disease. And it's important to remember and to try to instill the knowledge in the parents that you are on the same team as the parents, and in fact the relationship between the anaesthetist and the parents is perhaps the most important one. Honesty and warmth are your best assets in a stressful situation. I think in this job, as in life, you need a cool head, a warm heart and a thick skin. And stay cool. Thank you.
Thanks, Peter. Our next speaker is Dr. Greg Moloney from the Mater Children's Hospital. Greg also has a career where he spent 12 months in the UK, 18 months in Canada, spent some time in NICU and PICU, and also working in PICU at the Mater Children's Hospital. He was director at the Mater Children's Hospital for 8 years and learned little about anaesthesia, but learned a lot. His interests are in spinal surgery and now undertakes paediatric cardiac surgery. He's a Part 2 examiner. He's a very busy man. In his spare time, he is learning Italian because he's worked out that those around him have more than 2 languages and he wants to keep up. He's had a long interest in iatrogenic hyponatremia and in fact was instrumental in removing 3% and a third or half and half from our fluid stores at the Mater Children's Hospital. Thanks, Greg.
Thanks, Fiona. My talk will be nowhere near as entertaining as Peter. It's a bit of a dry talk, but I'll start it with something amusing about one-breath inductions. I must say I was confronted one day when I explained it to a teenager to take a deep breath in and hold it at the top, and he said, "Oh, like a joint." So, anyway, he performed it quite well. So it's said that in any given talk in this sort of context that you only take away three things to remember. How do I advance? There we are. Three points. So I'm going to give you those 3 points now and then spend the next 15 minutes trying to justify them scientifically, physiologically, and from a practical point of view. So the three takeaway messages is: 1, in the perioperative period, never use hypertonic dextrosaline solutions in children and infants. 3 1/3, 4 1/5, and 5% are now out. Point 2, the current 4-2-1 maintenance regimes are too generous in a sick child, and they should be reduced to 50 to 75% of their current value. Point 3, prescribe IV fluids like you would prescribe drugs. If you go through the literature and find out the problems of intravenous fluids, they surpass in percentage the problems of the drugs we prescribe. So I think IV fluids should have the same surveillance. They should be indicated, they should be reviewed regularly, and you should monitor their side effects. So back to point 1. In the perioperative period, never use hypertonic dextrosaline solutions in children and infants. There have been 10 randomised control trials and a meta-analysis published in Paediatrics in January of 2014. And this meta-analysis was the last piece in the jigsaw puzzle to sew up this topic. Before, it was always opinion of enthusiasts like myself who used to become incandescent with paediatricians, with their practice. But now, with this publication, we can say with the result of the meta-analysis of 10 randomised control trials that you are at a significantly higher risk of developing hyponatremia by a factor of 2 and by developing severe hyponatremia by a factor of 5 if you prescribe hypotonic solutions post-operatively. There was no significant difference found between the two interventions in the risk of hypernatremia, which is frequently quoted as a reason why you would give a hypotonic solution, because you don't want them to become hypernatremic. So, in conclusion, isotonic fluids are safer than hypotonic fluids in hospitalised children requiring maintenance IV therapy in terms of plasma sodium. So please use only normal saline, hearteners, ringers, plasma-light, and if they need dextrose, which I'll discuss in a moment, add some dextrose to the isotonic solutions. Don't use a hypotonic solution. But why have we been going for 5 decades with the guidelines that we have? Why am I completely reversing what is embedded in all of the textbooks? Where did we get our guidelines from? They come from this article in 1957, The Maintenance Need for Water in Parenteral Fluid Therapy by Malcolm A. Holliday and William E. Seagar. We all learnt, like I did in the early 80s, 100 mils per kilo per day for the first 10 kilos, 50 mils per kilo per day for the next 10, 20 for all 10 groups after that. 3 millimoles per kilo per day of sodium, 2 millimoles per kilo per day of potassium. That's what we were taught, that's what's become embedded, the 4-2-1 rule, and that's what we continued to prescribe. 1957, it was, make no mistake, it was a major advance, and it synthesised studies that had been happening since the 20s into renal fluid homeostasis, treatment of shock in adults, the treatment of gastroenteritis in children. They themselves did original work with kids in the study, but it was, and it was the simplification of it that made it so popular. Prior to that would be complex tables in paediatric wards and emergency departments where you'd look up the kid's weight and their condition and you'd follow a table and so forth. This simplified everything. But it had faults, and they became obvious fairly early on. The data was from normal healthy subjects, not sick kids. There were not huge numbers in their cohort, only 50 subjects, and many of them breastfed infants. The formula was a best fit. Always be suspicious when you see something that goes 150, 20. Round numbers, very suspicious. The data is now more than 50 years old, and it was never subjected to a trial. In their defence, they wrote this at the end of their article: as with any method, an understanding of the limitations of and the exceptions to the system is required. Even more essential is the clinical judgment to modify the system as circumstances dictate. It's a nice way to finish your article, but for the next 50 years, they tried to defend it, defend their regime. And in fact, I gave this talk, this is my soapbox issue, I give this talk all the time. I managed to find that 47 years later, these guys were still publishing. And in my last sort of literature review before giving this talk, I jolly well found them again 50 years later, still publishing. Interestingly enough, the conclusion at the end of this one is that there was a call for well-designed studies. So what is the problem? The problem is hyponatremia. Hyponatremia almost universally results from the retention of electrolyte-free water after the administration of hypotonic intravenous fluids to children with high circulating ADH. There's more than 50 literature-reported deaths, and I just want to sort of point out that Phil was talking about rearranging practices with a few deaths from codeine in all of North America. The literature is full of iatrogenic hyponatremic deaths on all 6 continents. I have found in all languages published items where this phenomenon has happened. It's a worldwide phenomenon, and the mechanism is pretty clear. So who's at risk from hyponatremia? All those with high circulating ADH, or all those who have a non-osmotic stimulus to ADH secretion. So what's a non-osmotic stimulus for ADH secretion? Well, if you're septic, particularly CNS and respiratory, but any sepsis, those two are particularly prone to it. A stressed individual who's breathless, or someone who's post-ictal, an injured person, a post-operative person, a person who's had anaesthetics or opiates. So, who's at risk of hyponatremia? All sick children bound in hospitals. And found this 10 years ago, courtesy of one of my registrars returning from England. This poster sits in paediatric wards in the UK and is actually a Department of Health document calling for people to be aware of the risk of hyponatremia with post-operative fluids. So are you convinced? Well, I took it to the paediatricians at my institution and I got, well, I've never heard a problem, I've never seen it. Oh, well, yeah, but it's really rare. So, and no one's going to listen to me, so I went looking. And so I did went to the Mater Children's Biochemistry Director, and we did an audit for the first 3 years that the current Mater Children's open, and typed in sodiums under 135, and that only found 5,000 blood samples. So Greg can't look those up, so we typed in 130, and we came up with 722 specimens with a sodium of less than 130. I'm sorry, these are children between 3 months and 15 years. I thought the neonates is a too hard basket. So I can't look up 722, so we then went to 126, and we chose 126 because that's a 10% drop, and your CSF volume inside your skull is 10% of the volume. So once you have dropped 10%, you have used up all of your compensatory mechanisms of squeezing CSF volume out as your cells expand. So we chose that, and I found 24 patients. And amazingly, 8 of them had von Willebrand's disease, and so they had received desmopressin as part of their perioperative therapy. And then I found a heterogeneous mix of 16 patients, 4 of which who had had seizures. And it was a litany of poor fluid management. And it was something I'll allude to a bit later. despite blood tests and despite fluid balances, the junior houseman had written the same fluid every single day, watching it get worse, because that's what they're taught to do. So why do we miss it? Well, we don't actually need IV fluids a lot of the time. The kids aren't that sick. They have a low stress surge. The IV is not in for long. There's a small water load before the child is thankfully put back in charge of its own sleep-salt axis. So we miss it because it doesn't really occur, and away they go. But it's the kid that continues on it is the problem. Secondly, we seldom measure sodium. No one wants to put the kid through an unnecessary poke when the IV's only in for 24 hours. And when an incident does occur, it's frequently of a complex nature, and so it's explained by something else. It's the elephant in the room. We just see something else occurring. And I just have to share with you one of the incidences I found on my audit was a child came in with a 18-month that fell off a coffee table, got a fractured femur, and was put on some IV fluids. Mum said that she had von Willebrand's, so kid might have it, it's got a fractured femur, let's give it a shot of desmopressin. They stuck it on its intravenous fluids. 24 hours later, the kid had a seizure, and the paediatrician, seizure, broken femur, get in the scan team. So this child suffered an iatrogenic complication, and immediately they're looking at the parents as though it's a victim of child abuse. It's just you choose to see what you want to see. Anyway, IV fluids. What do we know now that was not known then about intravenous fluids in children? The link between high energy consumption and water requirement has been challenged, and it's basically an aphorism that doesn't hold. The resting energy consumption in a sick child, interestingly enough, actually goes down, with the exception of burns. The kids drop their metabolic rate while sick for a bunch of complicated reasons, but they're actually only chewing up about 50% of the calories they do when they're actually growing and well and active. The ADH's levels are proven to be high. The urine is much more concentrated than Holiday and Segar had assumed or calculated in their healthy kids. And more sophisticated testing has shown that insensible water loss is more likely in air conditioning is 400 mils per kilo per day, not 900 used by Holiday and Segar. And it can be as low as 330 mils per metre squared per day in renal failure patients, which roughly translates to 12 mils per kilo per day. So the new evidence would say that your insensible losses are 12 mils, your urine's about 25 mils per kilo per day, your stool's 10 mils per kilo per day, so your total water loss is 50 mils per kilo per day, not 100. So point 2, our maintenance regimes are too generous in a sick child and should be reduced to 50 or 75% of their current value. Okay, who needs dextrose? Actually, the need for dextrose is really quite complicated and variable, and we need a simple solution as a systems issue, but I don't think there is one, so that requires doctors to think a bit. Dextrose doesn't need to be added to your isotonic solution. Well, why is it necessary in the first place? And is that a requirement intra-op or post-op? So point 3, prescribe IV fluids like you prescribe drugs, whether specifically indicated for the situation involved, and review the need for it regularly. And monitor side effects. So dextrose in the intraoperative isotonic fluid. Well, your risk of going hypoglycemic intraoperatively is depending on who you are and what you're having done. Neonates are traditionally at risk. The frail, the undernourished, the diabetics, okay, accept that. Those children that come to you with prolonged starvation, either through accident from a nosocomial problem of inappropriate booking or theatre scheduling change, or the child itself has had a prolonged bowel condition at home and then gets starved when it comes to the hospital and ends up late in the evening and they're quite behind on fluids and dextrose, or a neuro kid who hasn't been able to ingest anything, any effective nutrition. So who is at risk is the first thing. In audits on children starved for theatre, most of the studies are more than 20 years old now, which kind of predates the Cote change to our practice where we give fluids containing sugar up to 2 hours beforehand. So this data is a bit old, but in most of the orders, they would show 1 to 2% of the kids starved from midnight do drop their BSLs into a problematic area. So there is well, you could look at it and saying 99% don't, but nonetheless, 1% of patients, and we do 9,000 a year at the Mater, and the Royal would do the same, 10,000. So that's actually 1% of 20,000 kids is, so you've got to think about it. But it's usually explainable and predictable, and it's my belief that it'll become much less with the widespread use of dexamethasone, certainly in the older children. Dextrose in your isotonic post-operative fluid. Yes, you should add it if there's an expectation of delay in effective nutrition. So prolonged starvation, the child's had a laparotomy, they are going to be so bombed out on their pain relief that they can't really ingest effective nutrition. And the last one there, I say tonsillectomy. Should we include it? I mean, traditionally, no. Most tonsils most of them follow in a straight line and get out of hospital the next day. But you always have those ones that don't feed afterwards, don't take in effective nutrition. And because we do so jolly many of them, 2,500 a year at the Mater alone, if you've just got a tiny percent of those that don't feed, then you are going to multiply that by the enormous numbers we do. You are going to capture some kids that would have been going hypo. So I prescribe an isotonic solution post-operatively that does contain some dextrose to my tonsil kids, knowing that the vast majority of the time it's unnecessary, but at least I'm going to capture the ones that I can't keep an eye on day 2 post-op. Also, we give the dextrose slowly so that the risk of hyperglycemia is quite low. How much dextrose? This is the traditional amount put in neonatology textbooks that the neonates need 4 to 6 milligrams per kilo per minute, which generally equates to a 5 or 10% solution run at maintenance. That's what they write. This is patently unnecessary for older children, and the European studies of the last 10 years show that it is in actual fact unnecessary for neonates, and that 1% in the intraoperative course for neonates is enough to avoid hypoglycemia, and that has been reconfirmed time and time again. It started with Isabelle Morat in Paris there in 2003, and they're actually doing trials, in fact post-release trials now, of a 1% solution that they run intraoperatively, and they've studied it in neonates, and they've got virtually 0 hyperglycemia, and there were no hypoglycemic patients, and that's running decent volumes intraoperatively. So this is the study that of several hundred children, all of them neonates, and they were jolly proper neonate, prems, major laparotomies, etc., all having this fluid, and they didn't show any untoward electrolyte disturbance or hyperglycemia. So, new evidence. The dextrose requirement to avoid hypoglycemia is as likely as low as 1% solution, none of the 3%, 4%, 5% that has been traditionally dished out. So intraoperatively, you need dextrose either 0 or 1% at max. Postoperatively, 0 if you're going to get effective nutrition quickly, or something to tide you over, and the answer's not known, anywhere between 1 and 10%. At the Mater, 20 years ago, Bruce Lister went away to Baxter and asked them to make up a Hartmann's in 5% dextrose solution, and Baxter will make anything for you if you buy it. And so we have been using Hartmann's in 5% dextrose since that time. People ask me, is not the 5% too much? It probably is, but we don't use it intra-op. We use it post-op at low maintenance amounts, and it doesn't seem to be a problem. But I'm not by any means advocating that 5% is the answer. That'll become known in years to come, but probably 1 is all you need. So, in short, the new evidence, we give too much water because we are unable to excrete it under stress. We don't need as much glucose as we thought, and we excrete far more sodium than previously thought. So we need to change our practice because, as Mark Twain says, if you always do what you always did, then you'll always get what you always got. So, change to what? There's no one ideal solution, but your change must be something simple and understandable. And what we did at the Mater, Phil Sargent and I, by taking all of the data and holding everyone's hand, we made a rule that the first bag ever put up has to be isotonic, and you can only change to a hypotonic solution with a consultant's decision. And it's just, the issue just so rarely comes up, it's never changed, and those bags are sort of locked away in a cupboard with a key and a picture of a nuclear sign on it or something. So the risk of hypernatremia was always a worry, and it doesn't seem to be brought out in practice, but I do think I would still watch that, because even when you put the meta-analysis together, you're still only talking a bit over 1,000 kids, so I do wonder if there's a very low incidence of some kids spiking a high sodium if you really fill them full of isotonics. Is edema a problem? Probably not, but some people at level 3 evidence say it's not good if you have a neurological injury to have peripheral edema. Education, educate people that there's no one easy solution and that they should think, individualise and monitor. But systems issues, everyone knows that doctors are at their most dangerous when they think, and they'll favour protocols above thinking, and protocols are a good response to rapid staff turnover, which is very common at the junior level in public hospitals. So whatever your choice is at your institution, make sure it's robust. So systems issues, protocols protect you against errors, staff variability, but they do dumb down your staff. What do I currently do? I use an isotonic solution intraoperatively and in the early post-operative period, and then when I think dextrose is needed, I run Hartmann's in 5, because that's the bag we have available, and I run it at 75% maintenance thereafter. But I have a number of important caveats, and I'd like you to take those away, is that the review each day and the need for the fluid, and if it's going to be ongoing, a child should have electrolytes each day. Rapidly let the kid take over, decrease the IV rate, and let oral first govern it. And some important caveats, and beware of these patients. For any child who has von Willebrand's disease and gets desmopressin, any child with a significant neurological or respiratory illness, they should be put on a total fluid restriction. They shouldn't just watch their fluid balance, they should be prevented from going above 50% of maintenance. Fortunately, in our hospital now, the desmopressin comes from the haematologists, and they actually know about it, so they actually set a 50 mils per kilo fluid restriction for the kids, which is helpful. Okay, and closer monitoring. Only accept hypotonic solutions when the stress is gone and the oral intake is unachievable. These circumstances are rare. So in summary, only use isotonic solutions, reduce your maintenance, and prescribe IV fluids like drugs. Thank you.
Thanks, Greg. Our last speaker is our only non-Queensland speaker, and Catherine Olweny hails from Melbourne and is based at the Royal Children's Hospital there, where she's been since 2009. I first met Catherine through Spanza when, in my presidency, one of the things that I'm most proud of is to have established a journal watch through Spanza, but I can absolutely take no credit for it whatsoever, and Catherine has all of that. And she organises the journal watch, which is available to Spanza members and then on the website afterwards. It's a great summary of journals in current paediatric literature that you might like to access that paediatric anaesthetists find interesting, and Catherine coordinates that. Catherine also coordinates the clinical practice guidelines at the Royal Children's in Melbourne. This talk that she's about to give was part of a session that was at Spanza last year, and I think this is probably the topic that, and this talk in particular, that has most significantly changed my practice. So I call Catherine to the stage.
Thank you very much, Fiona, and good morning to you all. Unfortunately, there's not a PC up here, so just bear with me for a minute. Okay. Good. Okay, so I'm going to talk about anaesthesia for muscle biopsies, which presents for paediatric anaesthetists a dilemma and quite a challenging anaesthetic to prepare for and plan for. The two pictures I have on display present the two of the common presentations of infants presenting for muscle biopsy. The first is the floppy infant, and the second is the child with arthrogryposis. So arthrogryposis is a condition where infants are born with multiple joint contractures, and they may affect the spine, including the cervical spine, as well as the jaw and the mouth as well. Which button do I press to advance it? Is that right? Okay, so I'll start with the case presentation. So this is a case that I was involved with. It was a 2 kilogram, 3-week-old infant delivered at 36 weeks with severe hypotonia. The infant was CPAP dependent at birth, and there was a paucity of movement and arthrogryposis. The infant required skin, nerve, and muscle biopsy. Oh, going the wrong way. Okay, so the echocardiogram was normal, and the child had a small PFO. The cranial ultrasound and renal ultrasound were also normal, and the patient had a normal lactate and no serum CK had been performed. The EMG study was also normal. Nerve conduction studies were not suggestive of a nerve problem, but suggestive of myopathy or a neuromuscular junction disorder. The chest X-ray was normal. The MRI scan of the brain was also normal for gestational age, and a lumbar puncture was planned for this infant. So that was my response when I saw that patient booked for anaesthesia in a couple of days. And whilst most of you may not actually be faced with this particular clinical scenario, I think that the children and infants with muscle disorders and no definitive diagnosis present quite commonly for surgery and anaesthesia for things like MRI scans, orthopedic procedures, and trauma. This clinical scenario will form a framework for the management and planning for the care of these patients. And I think there's four main areas that need to be considered when planning for these patients to present to theatre. The 4 areas that I'd like to talk through are the likely diagnosis that these patients may have, what is the perceived risk of complications for these patients, and what are the requirements for processing of the muscle biopsy specimen itself. The final area is the risk associated with the end organ effects of the underlying muscle disease. So what is a likely diagnosis? In general, I think the large number and scope of muscle diseases that may present is probably beyond the scope of this talk, and it's almost certainly beyond the scope of our specialty as anaesthetists. So really we're reliant on consultation with treating neurologists and or metabolic physicians to guide our practice. But unfortunately, physicians may actually not be aware of the implications of the requirements that they place on us when caring for these children. So it's important that we actually have an understanding of the classification of muscle disease and also an understanding of the implications of what anaesthesia may have on the underlying disease process itself. So to start with, a classification of muscle disease or myopathy. So myopathy is a heterogeneous group of disorders with diverse etiologies that affect skeletal muscle and also skeletal muscle metabolism. There is usually no involvement of the nervous system or the neuromuscular junction, but cardiac muscle may be involved, and that can lead to cardiomyopathy in advanced cases. So myopathy can be classified as either acquired or primary. Patients with acquired myopathy may present for muscle biopsy, such as children who have polymyositis may present for muscle biopsy to guide a definitive diagnosis. But the group that we're most interested in presenting for muscle biopsy are the patients with primary myopathies. And they can be divided into 3 groups: the muscular dystrophies, the congenital myopathies, and the metabolic myopathies. So the muscular dystrophies represent the largest group of disorders that we may be faced with. The two most common ones are Duchenne muscular dystrophy and Becker muscular dystrophy. The other diagnoses are not quite as common, but patients with limb-girdle muscular dystrophy may present quite a similar picture to those with Becker dystrophy and Duchenne muscular dystrophy. They have pseudohypertrophy of their calves. In the early stages have a markedly elevated CK and also present with a progressive cardiomyopathy. Patients with facioscapulohumeral muscular dystrophy are not as severely affected and will have a moderate elevation of their CK. The patients with Emery-Dreifuss muscular dystrophy may in fact have a normal CK at baseline. And there are other even more rare forms of muscular dystrophy. The unifying process for these conditions is that the lack of dystrophin means that muscle is unstable and susceptible to recurrent cycles of breakdown and regeneration. The second group is the congenital myopathies. These conditions include central core disease, Nemaline rod myopathy, multi-mini core myopathy, and centronuclear myopathy, as well as type 1 fibre predominance. These conditions are of interest to the anaesthetist because they are associated with gene defects involving the ryanidine 1 receptor. So patients with these conditions are susceptible to MH. So moving on to, I think this has skipped a slide. Sorry. There was one other slide which describes the metabolic myopathies, and those are conditions that involve defects in metabolism affecting ATP supply. So the congenital myopathies include glycogen storage diseases, lipid storage disease, and disorders of pure nucleotide metabolism, and the last group is the mitochondrial myopathies. So those metabolic myopathies, perhaps I'll go back to the other slide so you can see where they fit. So those are the ones I'm talking about, the last lot, the metabolic myopathies. These are important to the anaesthetist because patients presenting with metabolic myopathies can have significantly deranged metabolism in the perioperative period. So these patients tend to exhibit quite poor tolerance to fasting. They may not be able to tolerate fluids containing lactate, for example, and they may require continuous infusions of dextrose during fasting. The perioperative fluid management will often require input from a metabolic physician to avoid decompensation in the perioperative period. The most important group from an anaesthetic point of view are the patients with mitochondrial myopathy, because in these patients, the use of propofol and other anaesthetic drugs may actually provoke acute decompensation of their metabolic homeostasis. So moving on to what is a likely diagnosis again with these patients. There are certain conditions or presentations that are more likely to suggest a muscular disorder, and they include the things that I've mentioned before: a family history of muscle disease, the presence of arthrogryposis, patients who may have developmental delay and or seizures, patients who present with cramps, and patients who may have rhabdomyolysis in response to exercise or following general anaesthesia. The other important factor is patients who have an elevated CK at baseline. Another group of presentations that would suggest a metabolic disorder include multisystemic involvement, progressive encephalopathy, global developmental delay or regression, an elevated lactate or pyruvate, increase in systemic S-carnitines or altered amino acids, and metabolic disturbance following minor illness or a change in diet or acute fasting. So moving on to the risk of rare complications. The rare complications that we're interested in with these patients is malignant hypothermia, anaesthesia-induced rhabdomyolysis, and propofol infusion syndrome. So I'll start with malignant hypothermia. There's only a small number of the numerous diseases of muscle that have been found to be associated with MH. And in these conditions, an abnormality of the ryanidine receptor gene is implicated. So going back to the table looking at the primary myopathies, the conditions that we're interested in here are the congenital myopathies, the ones appearing in red. So if we have a look at this table here, which is looking at the core myopathies, we can see that the gene implicated in these diseases is often the ryanodine 1 receptor gene. So for central core disease, it is that particular gene defect. Multi-mini core disease and Nemaline rod myopathy have multiple gene defects associated with them, but certain subsets actually involve the ryanodine receptor. So these patients, when presenting with these conditions, have to be assumed to be MH susceptible. So this table shows a summary of the conditions that have been found to have a ryanodine receptor gene associated with them. And the diseases to remember and to have in mind are central core disease, King-Denderer syndrome, mini-core myopathy, and there is a condition that actually exhibits central cores as well as rods, resembling Nemaline rods, and it's kind of a mixed version of those two diseases, and those patients may be MH susceptible. Native American myopathy, which we are unlikely to see in our population, as well as Evans myopathy, which has been found in some literature studies to be MH susceptible. There are other conditions which have been thought to be MH susceptible, but when they've looked at the gene studies, they found that they're unlikely to be so. So looking at muscular dystrophy was obviously previously thought to be associated with MH, but a true MH association has not been found. The patients, however, are susceptible to anesthesia-induced rhabdomyolysis, and these can be quite difficult to distinguish from MH clinically. So metabolic diseases themselves are not associated with MH. There has been one case in the literature of a patient who had MH after receiving suxamethonium on a background of having a mitochondrial disease. Suxamethonium is a known trigger for MH and anesthesia-induced rhabdomyolysis and is clearly contraindicated in patients with muscular disease. So moving on to anesthesia-induced rhabdomyolysis, the second of our rare complications. Certain patients who are susceptible will respond with acute muscle breakdown when exposed to volatile anesthetics and to suxamethonium. This results in release of myoglobin, an acute elevation in serum potassium and CK. So this can occur suddenly and acutely intraoperatively or in the immediate postoperative period and leading to hyperkalemic cardiac arrest, or there can be a slower, more insidious progression with delayed myoglobinuria, a delayed elevation in CK, and delayed cardiac arrest. So this paper was published in Paediatric Anaesthesia in 2013, and it looked at a group of patients with Duchenne's muscular dystrophy and Becker dystrophy. They found that in this particular group of patients, there were 66 exposures to volatile anesthetic and no complications that they could attribute to volatile anesthetics. All the patients in this study were older than 8 years old. What's important about this paper is this is quite typical of what was seen in the literature in the past in relation to patients with muscular dystrophy, and in particular Becker dystrophy and Duchenne's, because those are the most common. The literature would suggest that it's okay to give volatile anesthetics. But what's important to notice is that these particular group of patients were all older than 8 years old. And it's likely that there is a change in susceptibility to rhabdomyolysis with age in patients with muscular dystrophy. So younger patients would tend to have a greater muscle bulk and will have much greater quantity of muscle that's undergoing cycles of breakdown and regeneration and is susceptible to rhabdomyolysis. As the disease progresses, this muscle generally tends to get replaced by scar tissue. The muscle bulk reduces over time, and patients may even start to show a fall in their baseline CK. So these patients are quite likely to be less susceptible to acute rhabdomyolysis as the disease progresses. So it's quite common to hear people say that I've anaesthetized lots of patients with muscular dystrophy and I always give them gas and there's not a problem. The other reason why this is important is because the condition is rare enough that you could do that 50 or 20 times and not have a problem and then have an event. So the take-home message for this particular condition is that younger children are more likely to be susceptible to rhabdomyolysis, so the newly diagnosed Duchenne's or the undiagnosed child presenting for muscle biopsy are much more susceptible. and the older burnt-out muscular dystrophy patients may be less susceptible. The problem with taking that approach is that some of the dystrophies are much slower progressing. So, for example, Becker dystrophy is a much more slowly progressive condition. So children can be quite older with Becker's dystrophy and still have significant muscle bulk and therefore be more susceptible. And that's likely to be the case for children with other forms of muscular dystrophy that are not as symptomatic and perhaps are more slowly progressive. So most guidelines have fallen short of declaring halogenated agents as being contraindicated in muscular dystrophy, but I think it's only a matter of time before the weight of evidence leads us to that conclusion. And there have been some recent cases in Queensland and in Australia that have illustrated this. So if muscular dystrophy success is suspected, halogenated agents should not be used. So moving on to the next rare complications, propofol infusion syndrome. So this occurs in children receiving infusions of propofol over long periods, so 4 milligrams per kilo per hour for 48 hours or more. This can, but not always, result in metabolic acidosis, rhabdomyolysis and lipidemia. Cardiac failure and bradycardia with cardiac arrest can then occur. So this slide looks a bit complicated. It's not really. It's going back to your sort of medical school physiology and understanding of mitochondrial function. This is a diagram of the respiratory chain enzyme present in the mitochondria, which are the energy factories of the cell. So energy-rich substrates are transported into the mitochondria, and then via NAD, electrons are donated into the electron transport chain, and they move from 1 to 4, and eventually ATP is produced by complex 5 to produce energy for the cell. In addition to that, fatty acids can be transported into the mitochondrion as well, and they can donate electrons to the electron transport chain via complexes 1 and 2. So propofol can actually affect mitochondrial function. So propofol itself inhibits fatty acid transport into the mitochondrion. Propofol also inhibits complexes 1 and 2 and complex 4. And propofol uncouples oxidative phosphorylation at complex 5, which is the final energy-producing step. Propofol can also be a significant lipid load to the patient. So when you have a patient presenting with a mitochondrial disorder or with a potential mitochondrial disorder, propofol infusion syndrome may actually occur at much lower doses and after shorter duration periods. So the florid syndrome may not be apparent, but short-term use could still result with delayed recovery and a need for intensive care. Unfortunately, the large number of genotypes and phenotypes of mitochondrial disorders means that predicting the safe threshold for a given patient is impossible. Most of the recommendations relating to the use of propofol in mitochondrial disorders is based on one very small case series and on a number of case reports. This particular case report appeared in Anesthesiology last year, and in summary, it was the case of a 4-week-old, 3.7 kilogram infant who presented for muscle and skin biopsy. The patient was hypotonic and somnolent and had a persistent metabolic acidosis. The MRI brain suggested that the patient had a mitochondrial myopathy. The patient received 5 milligrams per kilo of propofol, followed by an infusion. The total propofol administered was 44 milligrams, which works out to about 12 milligrams per kilo over the case. The patient was returned to the intensive care ventilator with a mixed respiratory and metabolic acidosis, and the metabolic acidosis did not improve, and the infant died 2 weeks later. So, as with many cases like this, it's difficult to tease out whether the deterioration was the progression of the underlying disease or and which aspect was directly attributable to the use of propofol in this patient. So the final conclusion from that is that propofol use in mitochondrial disorders is suggesting that the literature suggests that an induction dose is probably safe, but an infusion should be avoided. But a safe threshold for a given patient and a given disorder is unknown. So when we look at patients with mitochondrial disorders, it's recommended that a volatile anaesthetic be used in these patients. However, we need to anticipate that there may be increased sensitivity to volatile. Models have shown that complex 1 is sensitive to halogenated agents, and BIS studies have also shown the same finding. So moving on to the last section, requirements for the processing of the muscle biopsy specimen. So the types of muscle biopsies that are taken in children include the malignant hypothermia testing biopsy, the standard anatomical biopsy, and the muscle mitochondrial enzyme analysis biopsy. Other biopsies may be taken at the same time, some of them for mitochondrial studies and some of them for genetic testing. It's important to understand that all of these biopsies have requirements that may impact our conduct of anaesthesia. So starting with local anaesthetic. So local anaesthetic should not be used, is not allowed to contaminate any muscle biopsy specimen. Regional blocks can be used, but the site of injection must be sufficiently distant from the biopsy to ensure no contamination. And that can be quite difficult to achieve in a 3-kilogram infant if you're trying to, for example, do a femoral nerve block. The volume required is quite likely to track down and may actually encroach on the biopsy site. Local anaesthetic can be used, but only after the biopsy specimen has been taken. So in malignant hypothermia testing biopsy, a non-triggering anaesthetic is obviously required. The specimen is a live muscle specimen, and so appropriate handling, storage, and timely transfer for assessment is essential. The standard anatomical muscle biopsy also requires a non-triggering anaesthetic, and that's usually performed if muscular dystrophy or a core myopathy is suspected. So requirements for processing of the muscle biopsy specimen. So if it's a muscle mitochondrial enzyme analysis being conducted, propofol should not be used. As I've shown in the slides before, propofol will inhibit mitochondrial metabolism and therefore will interfere with the assay that they're performing. So the pathologists and the physicians will request that propofol not be used in these patients, and they may in fact request that barbiturates, the thiopentone, not be used for the same reason. So this ends up being quite a dilemma for the paediatric anaesthetist. In many cases, biopsies are taken for both anatomical and mitochondrial analysis, and in actual fact, when you look at the literature on this, in these undiagnosed patients presenting for muscle biopsy, the risk of an undiagnosed patient receiving volatile is probably greater than the risk of them receiving a small amount of propofol. But if the pathologists and the physicians are excluding propofol, we're left with a difficult decision. And I think in those situations, a thorough risk-benefit discussion is required between the physician, the surgeon, and the parents. So the last section is looking at end organ effects. So patients with muscle disease may have cardiac disease, so cardiomyopathy and abnormal conduction, respiratory disease and respiratory failure, bulbar dysfunction, reflux and aspiration risk, and they may have difficult airway anatomy and difficult IV access and metabolic derangement. So the group of patients most likely to present for muscle biopsy for anaesthesia and care are the patients with muscular dystrophy, and this was a consensus statement put out by the American College of Chest Physicians, which I would recommend to anyone who's interested in this topic. I'll also just briefly cover patients presenting with metabolic derangement, and these are the main points. Poor tolerance of fasting. They may need dextrose as a continuous infusion during fasting, so preoperatively and postoperatively. They may be intolerant to lactate, and perioperative fluid management will need consultation with a metabolic physician, and we need to avoid stress in these patients, as stress could increase metabolic demand, and these include pain and hypothermia. So going back to the case of our 2-kilogram, 3-week-old infant. So we rarely get patients presenting for muscle biopsy that are not a diagnostic conundrum, because advances in genetic testing have meant that only a few children now come to muscle biopsy, but they're obviously always the tricky ones. So for this patient, we looked at MH susceptibility as a potential concern, the risk of rhabdomyolysis and risk associated with propofol, postoperative ventilation, and drugs excluded by the metabolic and neurology team were barbiturates and propofol. So we were left with not many choices, and the two choices were to either do a spinal anaesthetic or to do a ketamine-based anaesthetic. I think in this situation we elected for a ketamine-based anaesthetic in this child. So the take-home messages are the following. Some muscle conditions may be associated with MH. Muscular dystrophy is not associated with MH, but volatile agents should not be used because of anaesthesia-induced rhabdomyolysis. Succinylcholine is contraindicated. Propofol may cause life-threatening decompensation in some patients. Patients with metabolic myopathy need careful perioperative management, and the end organ effects of disease are amenable to optimal anaesthetic management. Thank you.
I'd just like to ask all the speakers to come to the top table. I'd just like to apologise to the audience because, as I said, I'm a little bit computer non-savvy and I have lost the page where questions are. So I don't know if somebody can help me refresh that. I did see the first question, which was to Phil, which was regarding, and hopefully I can remember it, the switch from codeine to oxycodone, which is obviously a more powerful opiate. And did you have any comments regarding that?
It's a pretty open-ended question, but yes, there has been a switch to oxycodone, certainly in this town, and the advantage of oxycodone is that it works, because we know that codeine doesn't work in 10% of the population approximately, but it's a potent drug, and out in the community, it's a drug of abuse. So I'm quite concerned that the liberal use of oxycodone in hospitals is tracking out into the community. So it's certainly not the ideal drug, I think, to send children home on after a tonsillectomy, but that doesn't mean I know what the ideal drug is.
Thanks. Does anybody from the audience have any questions at all? Yes.
Well, I think my slide suggested that OSA was more common in boys, but apart from that, I have nothing to say on that subject.
Yes.
And I think that is a reasonable approach because you're faced with a situation where there's not a lot of information. The only caveat to that is that there are some conditions where the CK could be normal and you would still have a potentially triggering condition. Yeah. So just having a normal CK doesn't completely exclude the risk of a possibility. But what it does do, if the CK is elevated, then you're almost certainly concerned that they might either trigger or have rhabdomyolysis. So and a normal CK doesn't exclude the potential for risk. Lactate is very non-specific, so any number of conditions could lead to an elevated lactate. And having mitochondrial disorder is only one of them. So any of those other metabolic conditions which didn't appear on the slide, glycogen storage disease, may result in an elevated lactate. So the patients may or may not be sensitive to propofol in that regard. And we can't forget the other reasons that propofol may cause decompensation. It's a potent anesthetic, sedation, hyperventilation, all of those conditions. So a fragile infant who's only just holding on may deteriorate for those other sort of pharmacokinetic and pharmacodynamic reasons, rather than purely a direct effect of the propofol on the mitochondria.
Thank you.
Question to that, I was just thinking, these babies coming for MRI for these query metabolic or other conditions, they're really only a small component of a large group of floppy babies with developmental delay who present, and often enough just whiz through with the standard technique that anaesthetist uses. And I wonder if we're likely to miss more of these children as MRI becomes more of an investigation of choice. Is there a solution?
Yes, I don't think there is a solution, but I think what we can do is actually educate our physician colleagues about the potential, because what tends to happen to these children is that they present 1 week for an MRI scan and they come back a week later to have their spiker fitted, then they come back another week later to have the spiker removed, and then they might come back 2 weeks later for a lumbar puncture and a muscle biopsy. So each one of those events is a risky event for these patients. And so whilst we might not be able to avoid anaesthetising them, we can reduce their risk by reducing their exposure and reducing the frequency with which they present. And trying to, if the child is scheduled for a muscle biopsy in 2 weeks, do they need to have all of these other procedures before they have the muscle biopsy? Could that be delayed until we get some kind of answer or some kind of guidance? So I think whilst we can't avoid looking after these children, we can actually better manage them in conjunction with our physician colleagues.
I think we'll have time for one more question. Yes.
I'm sure there's an answer, but in 20 minutes I decided to duck surgical factors in pain issues.
Lovely. There's some housekeeping notes, but we'll call that session to an end, and I'd like to thank our speakers for some great talks. I'm sure if you have any questions that you would like to ask them, please feel free to do so at the end of the session, and enjoy lunch.